Hello, everyone. I know that the exam time can be challenging and stressful time for you, but I just want to remind you all of the incredible potentials that lies within each one of you. I know you have worked hard, you put in countless hours of study, and you overcome challenges, obstacles to reach this point. So I want you to walk into the exam room with proud. Remember that success is not slowly defined by the grades that you receive. It's about the dedication, the determination, and the perseverance that you have shown along the way. These qualities are what will carry you forward in life, far beyond any test or exam. So believe in yourself and in your abilities. My friends, I know that you have worked hard as the exam is approaching. I know you will be stressful. I know that you are facing difficult time now. Maybe you have difficulty in sleep. Maybe you have difficulty in maintaining concentration. Maybe you feel that, oh my God, I have now been lost in the middle of nowhere. But please stay calm, focused, and trust in your preparation. So take a deep breath, read each question carefully, okay, and tackle them one at a time. And you've got this. My friends, before the exam, I want you to be proud of yourself, to be proud of what all you have done so far, okay? So please go out there and give your best in the exam day, okay? Please leave no room for regrets. And when you walk out of the exam room, hold your heads high. Why? Because you know that you have done your utmost. So please be proud of yourself, trust yourself and your abilities, and believe in success. Okay? So today we are going to finish the obstetric revision module, which was like a quick revision on the obstetric or all the important point that important for your exam or the topics that important of your exam. I'm sure that there is still a lot to do and a lot to cover during your revision, okay? But I would like to revise some of the questions of the perinatal mental health with you. Why prenatal mental health is important. Guys, we have seen tragedies nowadays, okay? And in the last reports of the maternal deaths, there was pregnant women in their time where they are vulnerable and they are in need for help and in need for someone to understand their emotions and the hormonal change and the life change that they have been through. They are left alone, okay? And nobody could actually, listen to them. Nobody actually, okay, give them, time or excuse. Doctors are busy, seeing them in the clinic, check, yeah, baby's fine, heart rate is okay, placenta is up, head is down, go home. And they are busy, they want to see the next one, and so on. Husband, family, friends, oh, you're not the first one who got pregnant, right? So, my dear friends, most important lesson that we learn from our journey to study the eMRCOG that I would like to tell you, really, 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 be a good doctor, okay? Change yourself from inside. Maybe you are very good at the moment. I need you to be even the best, okay? Listen to your patient and give them your, attentive listening, okay? And give them support when they need. You need to be aware, okay? And you are the most important profession dealing with pregnant women every day or on daily basis, and you need to be aware on how to catch, okay, the early signs of mental illness. And unfortunately, it's very common during the pregnancy and postpartum period, okay? So knowing the different problems that a woman face during her pregnancy and during delivery and postpartum, okay, is the first step to prevent the tragedies that I told you that happened from women committing suicide, or a woman went into an acute depression and then turned into chronic depression, affect all the family members, okay, because it wasn't catched and treated right during the pregnancy. Or even sometimes, we all hear about a postnatal woman, okay, and she killed her baby, or she killed herself, or even the family. So we don't want, my friends, to miss that, okay? You are a good doctors, and I believe that you will give all the support needed to your patient. Okay, so why the perinatal mental health is important nowadays in the exam? Again, that's because of the rising number of cases of victims, okay, during the pregnancy and postpartum. And this rising number nowadays is increased in the eMRCOG, or in the report of maternal morbidity and mortality, okay? And we need to know how to catch up, okay, those problems. For every pregnant woman who comes to take care, okay, during the antenatal or the postnatal, we need to screen them for depression, especially those at high risk of depression. Some of the patients are already high risk. Some of the patients, excuse me for the voice, some of the patients are already high risk because that they have previous history, or they have specific condition with chronic depression, or even with positive family history. So we need to know which patient is at high risk, and how about the low risk? Low risk women also need to be screened, right? So the screening will be easy by a questionnaire. We start by the 2 holy questions, asking the woman about her mental health. It's the screening, right? It's a part of every antenatal visit. By asking, during the past months, have you often been bothered by feeling down, depressed, or hopeless? During the past months, have you often been bothered by having little interest or pleasure in doing things? Is this something which you would like help for? Okay, and then after that, we can apply, if the woman answered yes to one of these questions, we can apply the questionnaires. The questionnaires, you need just to know the names of the questionnaires, okay? There is a depression questionnaire. It's called Edinburgh Postnatal Depression Scale, okay? So the Edinburgh Postnatal Depression Scale is the most frequently used screening tool, okay? And it's just a self-report 10-item questionnaire used in post-antenatal and postnatal phases. And it have been actually used widely in the UK, and it has positive predictive value of 57% and negative predictive value of 99%, okay? So it's very good as negative predictive value. The other questionnaires available, we have the patient health questionnaire, which is a multiple choice self-reported questionnaire, and it's also a screening tool for mental health disorder, okay, including for both depression and anxiety. For anxiety alone, there is 2 types of screening. There is the GAT2 and the GAT7, okay? So the GAT2 are 2 questions, okay? Questionnaire on the first level. And according to the answer, okay, we can follow by the GAT7, okay? So the generalized anxiety disorder scale, called the GAT2, over the last 2 weeks, how often have you been bothered by following problems? Okay, what are the problems? Feeling nervous, anxious, or on the edge, or not being able to stop or control worrying. If the woman answered yes, we'll follow by the GAT7, okay? So simply, this is the screening for anxiety, this is the screening for depression, okay? This is for low-risk pregnant woman, for everyone pregnant and postnatal. During the discussion of the woman about her mental health, you need to understand and identify the red flag in prenatal mental health. Why? Because those red flag signs, if available, if it's present in a woman, this will be at high risk of both psychosis and suicide. So the red flag signs that you need to know them very well is as follows. It includes recent or rapidly changed significant alteration in the mental health, emergence of new symptoms, which can include psychotic symptoms like delusions or hallucination, or severe anxiety in relation to infant or the children welfare. Psychotic symptoms that involve the infant, okay? Sometimes he will tell you that she believes that her baby can speak, or her baby is talking to her, or something like that. Thoughts of violent self-harm or suicide. Acts of violent self-harm or suicide. So the woman can only think about harming herself or the baby, or she might start acting to harm herself. Also, new, persistent, non-reassurable ideas and the expression of these ideas. Okay, this is all are red flag signs, like feeling that she is incompetent or inadequate as a mother, or feels estranged from her infant. Also, pervasive guilt and hopelessness, deterioration in function, okay? Like what? Like neglecting her self-care, her hygiene, care of the infant, avoidance of the infant, not eating or not sleeping, severe insomnia. And then comes the role of the psychomotor retardation. Signs and symptoms of the postpartum psychosis is very important for you, okay? So the first early signs can be non-specific, which make it very difficult to diagnose at the beginning. So it can be non-specific with symptoms such as insomnia, agitation, or odd behavior. Then progression is often rapid, and a few hours later, the woman is considered psychotic and often severely disturbed with hallucination, delusions, fear, and so on. So now, my friends, okay, you need to understand that we need to act fast, right? We need to act fast to save the woman. That's why psychosis considered as emergency is considered as obstetric emergency. And the woman must be seen in how many hours? Anybody, if you know how many hours? We need the woman to be seen by a psychologist. 4 hours. Well done. Okay. So the 4 hours that the woman need to be seen through this time before the rapid deterioration of the action, right? So that's why we call that the diagnosis and management. It's a psychiatric emergency, and women require assessment by trained psychiatrists. In particular, they should pay attention to suicidal and infanticidal ideas. Okay, check for the well-being of the baby. Okay, so if the woman found to have early signs or symptoms of psychosis, where to keep her? You need to keep her in a special mother and baby unit. Okay, so the mother and baby unit is a unit where there are facility of staff, trained staff to take care of the mother and take care of the baby. Okay, why it's important to keep the mother and the baby in the same place with one-to-one support from the staff? Okay, and the mother will be supervised by one-to-one registered mental health nurse, so she's well trained. Why? Because she is trying, okay, to calm her down, and she's trying to build a bond between the mother and the baby, but of course after stabilization of the mother condition, right? Okay, so the mother will receive treatment, okay, in the form of medication, or in some unresponsive cases you may even discuss the ECT, where again in the mother and baby unit. Why this is important? Because this is a question of the exam. Okay, so how about the prognosis of this case? If the woman had developed psychosis once, do you think that she is at high risk of recurrence in the next pregnancy? Or she is at risk of developing other mental health problem in her life? Like when we have gestational diabetes, the woman is at high risk of diabetes afterwards, right? Yes, of course, both are there, okay? So the recurrence rate in the future pregnancy that she will develop a postpartum psychosis as well in the future pregnancy is reach to up what level, my friends? 50%. Okay, so if you have two women develop psychosis, one of them will have psychosis again in the next pregnancy. This is very important exam question. Another question, ask you about the percentage of women who had psychosis in the future. What is the risk to develop bipolar disorder or mood stability, mood liabilities? The woman will be on a high risk of bipolar disorder, 35 to 65. So among three women, who got psychosis, how many will develop later on in life bipolar? One or two. Okay, 35 to 65. So it's 1/3 to 2/3. Okay, my friends? Okay, so this is very important numbers for your exam, right? Okay, so how about taking care of a pregnant woman? Now you are the doctor, you are in the clinic, okay? And all of you know that in the UK there is mental health team. One is community-based, means that it's in the community near the woman GP, and maybe a specialized nurse can also visit the woman or follow her up at home and so on. And one is hospital-based team of the mental health. The perinatal mental health service, okay, referral is indicated in which woman? So you have now seen a patient in the antenatal care. What are the indications to refer a patient to the perinatal mental health service? Either the community-based or the hospital-based. Number one, woman with current illness where there are symptoms of psychosis, severe anxiety, severe depression, or suicide thoughts, or self-neglect, or harm to others, okay? Or significant interference with daily function. So those are red flag signs of psychosis. So this woman will need to be seen urgently in the perinatal mental health service, right? The woman with obsessive compulsive disorder or severe anxiety, and here I'm not speaking at all about mild anxiety cases. Here I speak about a woman who had something that affect the quality of her life and interfere with her relationship to others. Severe, yes, severe everything, severe anxiety, right? Good. How about obsessive compulsive disorder? Yes, she need the obsessive compulsive disorder, she need. Yes. How about a woman who had bipolar symptoms? At the moment, this is urgent referral. So how about the woman with history of bipolar or schizophrenia? Do you think such woman will need a referral as well? Yes, of course. Why? Because she's at high risk of developing this again up to 50%. Good. Woman with previous serious postpartum mental illness like psychosis. Same thing, right? Woman on complex psychotropic medication regimen. So she is receiving at the moment medications. Referral should be considered for woman with illness of moderate severity if developing late in pregnancy or early postpartum. Woman with current illness of mild or moderate severity where they are first degree relative with bipolar disorder or puerperal psychosis. So in the family history is a risk factor. They speak here about first degree relative. They speak here about family history of psychosis, not only personal history of psychosis. So do you think that they carry a risk? Yes, so the women who have an anxiety, even if it's a mild or a moderate anxiety, and we know that the treatment of it is just facilitated self-help or a CBT for the moderate cases, okay? If this woman have first degree relative, shall I consider referral here? Yes. So in exam take care. Sometimes he tell you guys after the exam come and tell me that there was a woman with mild anxiety, moderate anxiety. What is the management? So based on what you said, you give me one word, right? One word, a woman with mild to moderate anxiety. So I will answer facilitated self-help, right? But in exam, if the story, because in the exam, he's not going to give you few words only, he will give you a scenario. So take care from the scenario. If he mentioned family history, then this case, okay, we will consider her for a referral to the perinatal mental health team. Okay, darling? Dear friends, will you promise me? Read the whole scenario and check if the woman had a personal history of mental health, okay? Current history of mental health, symptoms, or family history, especially in the first degree, okay? Okay, my friends, please do that. So you will tackle the question, correctly in the exam. Okay, so those are the indication of referral to the perinatal mental health team, okay? Women with previous periods of inpatient mental health care should be screened by the mental health service, either by assessing case record or seeing the woman, okay? The maternity service need to ensure the appropriate communication with the primary care and social service where necessary. Why? Because, my friends, sometimes this woman who maybe she's a single mother and she had history of prolonged depression or bipolar depression, something like that, okay? So she had only one child. So the maternity service with the perinatal mental health service, maybe social service can help as well if according to her condition, right? Maybe she needs a social help. Okay. Especially for the woman who declined the referral. Okay, so this will be even at higher risk because she declined the referral. This table show you, my friend, some of the conditions that may have the depression or the anxiety as a part of the signs and symptoms of this medical problem. Okay, so tuberculosis, lymphoma, SLE, encephalopathy, subarachnoid hemorrhage, eclampsia, pneumonia, subarachnoid hemorrhage, all of these, okay, can show the symptoms of anxiety, depression, or sometimes even with the tuberculosis show like loss of appetite, loss of hope. Okay, so the woman will appear like she is depressed, while however this is a part of the disease, not absolute depression. Okay, so let's have a look to the depression itself. Okay, so I started with the psychosis because psychosis is the most important one. Now come to the depression, please. Depression is very common in pregnancy. However, if left untreated, okay, it can cause symptoms like the woman can go for a chronic depression, the woman can go for a severe depression, the woman can go to a suicidal thoughts, the woman can even commit suicide, right? So the depression in pregnancy is very important that you catch it, treat it, right? If the woman had mild to moderate depression symptoms, what you will do? Do you think that the woman will be referred to local psychology service? Yes, mild to moderate depression will be referred to which place? Local psychology service known as IAPT. What is this IAPT? It's improving access to psychological therapies. Okay, service. Or primary care mental health service. This is in the community. So this can be a correct option in the exam. Sometimes in the eMRCOG, you find so many options, but you're looking only for the low intensity psychological input. Okay, or the facilitated self-help. You can't find them, but you can find another one which is correct, right? So the improving access to psychological therapy service or the primary care mental health service, okay, they will offer this woman what treatment for the mild and moderate depression? Low intensity psychological input, which is include reading and accessing online material based on cognitive behavior model. Okay, so people who are looking in the exam for CBT alone, cognitive behavior therapy, it could come to you in a different presentations, right? So the low intensity psychological input, okay, this is the treatment based on the CBT model, okay, principle, and it's a self-help treatment. So she will access the online material based on cognitive behavior model. She will finish this course, which is 9 to 12 weeks, with 6 to 8 sessions of face-to-face or telephone contact with a facilitator. Okay, so a facilitator will visit her at home, or she will have a over the phone, or sometimes can be online nowadays, the video. Okay, along with the course. Okay, so this is what is called a facilitated self-help, right? So in the ninth guideline, when he tell you facilitated self-help, why it's a facilitated self-help? Because it composed of two things, facilitated and self-help. What is the self-help? The facilitated self-help. The self-help is an online course based on the CBT principles. What is the facilitated one? Facilitator is a facilitator. Somebody who is going to discuss with her the course and ensure that she understands everything and give her advice and maybe give her some task to do and discuss next time. Okay, so it's like little bit of psychotherapy. Okay, guys? Clear? This is the facilitated self-help, which is a treatment of mild to moderate cases of both depression and anxiety. Okay, but take care of the name comes in the exam, low intensity psychological input or referral to improving access to psychological therapy. Moderate to severe depression. The treatment choice will depend on the individual presentation. Okay, if the mother or the pregnant woman have moderate to severe depression, here is the time to offer her high intensity psychological intervention. What is this high intensity psychological intervention? Anybody know? Like CBT. Okay. Like a CBT, it's a session, like psychotherapy, right? So CBT can come in the exam and I couldn't recognize. Yes, it can come in the exam and I couldn't recognize. It came already, but under the name of high intensity psychological intervention. Okay, guys? So this is like CBT. Comes to moderate to severe depression. Pharmacological treatment. What pharmacological treatment I can offer to a pregnant or postnatal woman? SSRI, why not? Okay. SNRI also is another choice. Tricyclic antidepressant is another choice. In exam, he comes and asks you what is the safe SSRI or antidepressant during breastfeeding, which is during breastfeeding? It's the sertraline. Sertraline is considered safe, actually, for both pregnancy and postpartum, especially for the breastfeeding. Okay. How about combination of both? Yes, please. Combination would be even better. So the treatment option is either high-intensity psychological intervention like CBT or pharmacological treatment, okay, in the form of SSRI, or combination of both. Sometimes the severe depression comes with catatonic features and psychotic features. If it is psychotic features, the depression developed into turn into a psychotic problem. Okay, so here it will be antipsychotic medication instead of antidepressant medication, or a mood stabilizer would be used. Okay, and in life-threatening cases, ECT. Okay, my friends, so mild to moderate, again, what shall I do? Low intensity psychological input, okay? Or facilitated self-help, which is online course plus facilitator sessions, 6 to 8 sessions of face-to-face or telephone consultation with a facilitator. Moderate to severe, high-intensity psychological intervention like CBT, plus medication or combination of both. Severe depression, think about antipsychotic now, severe depression with catatonic feature or psychotic features. So it will be switch antidepressant to antipsychotic because it's now psychosis, and ECT. Is that clear so far, my friends? Okay, I hope it is. Okay, so let's solve some questions. Through solving questions, we can highlight important point because we have a lot to cover. So the best way is, to offer some concise questions and comment on each one. So my friend, the most common time of presentation of postnatal depression is the time of presentation is not the only way to diagnose in the exam. But another question, this is a straight question. This is just a recall of fact question. What is the most common time of presentation of postnatal depression? It is 2 to 4 weeks after birth and 10 to 14 weeks post-delivery. Okay, so either the time of 2 to 4 or the time of 10 to 14. Okay, yes, it has 2 peaks. Okay, so treating depressive disorder in pregnancy is important because what? Yes, suicide is a leading cause of maternal death. The woman who presents 5 days after delivery, she is very tearful and says that she is struggling to feed her baby and not sleeping well. Yes, she is tearful. Okay, so when she's just tearful and she's struggling to feed the baby, this is very common. Okay, and it's self-limited condition. It's just the baby blues, right? Here I just, wrote the red flag signs with red. So can you see it here? Woman present to the general practitioner at 5 days postnatal. She appears agitated and says that she has not slept for 3 days. She's talking fast and appeared confused about why she is there. So she is agitated, insomnia, confusion. This is red flag signs of psychosis. Yes, well done. It's psychosis, of course. Okay. A woman presents to her general practitioner 2 weeks after delivery. She appears on the edge and says that she's worried about germs in the practice that might affect her baby. She asked to wash her hands as soon as she enters the room. As you can see that her hands look red and raw. This is obsessive compulsive disorder. Is that something that needs treatment, my friends? Yes, referral to whom? Yes, well done. We refer to the perinatal mental health team. Yes. Look, my friend, when the problem is significant, okay? So a woman had mild anxiety or mild depression. This is something that can be, just helped by talking to her, facilitated self-help, the sessions with the facilitator, okay? And it's not something that's significant, okay? But people with obsessive compulsive disorders, they need help more than this, okay? They need to be referred to the perinatal mental health team. They need to meet a professional, okay, with experience on providing help for these particular cases, okay? A woman with tocophobia, a woman had fear of delivery, okay, and she doesn't want to deliver normally. She wants to go cesarean section because of the tocophobia. What you will do for her? Yes, she need a referral to discuss her fears with the healthcare professional with experience in providing perinatal mental health support. Okay. What do you think about the woman who had post-traumatic stress disorder? This is another woman who's not only having a tocophobia, fear of delivery, but she had, for example, difficult delivery or difficult accident, okay? And then after that, she is having, flashbacks, feeling of guilt, and so on. Post-traumatic stress. What type of interventions they need? Low intensity or high intensity? Yes, they need the high intensity. Yes, excellent. Well done. Okay. So a woman is seen 12 weeks postpartum with low mood. Her husband is concerned that she's not eating well and had no energy to do anything, including looking after the baby. This is postnatal depression. Okay, so please see this question, my friend. Yes, we will need to know some information about the medication because this is very important, for example, for the lithium. Okay, so what is the answer, my friends? The woman presented with antenatal clinic at 37 weeks with symptoms suggestive of depressive episode, so late in pregnancy, and she had symptoms of depression with anhedonia, sleep disturbance, increased anxiety, reduced appetite. She reported feeling of hopeless, worthless, and she disclosed suicidal thoughts. So this is also associated with past history of postnatal depression and family history of depression. So what do you think? Will you contact the GB or will you contact the local perinatal psychiatric unit? Guys, is that an emergency or not? This is an emergency. So you need to speak to the person, okay, that will help her. She need to be seen by a psychiatrist within 4 hours. So you contact the local psychiatric unit or liaison service to organize an immediate assessment. Okay? Yes. In this question, single woman had schizophrenia, experienced her first schizophrenic episode. He started the question with single, so this is the beauty of the part 2. Single. So single, that means what? She will need support and help. Yes. In the first schizophrenic episode, requiring inpatient psychiatric care. Okay? 8 months prior to pregnancy, she had been well controlled on haloperidol tapered injection since that time. She's currently at 36 weeks of gestation and she's well. She lives alone and has limited social support. So a woman with previous history of inpatient admission due to psychiatric problem. So now for her delivery, what should I arrange to help her? Yes, there is a specialist mother baby unit, the MPU, right? So she will be admitted in the mother baby unit, and this is a prophylaxis admission. Okay? This is not a treatment admission, this is a prophylactic. Why? Because you don't know. She had a prior history, so she's high risk of developing psychosis. If she went home, even if she appeared well after delivery, and she went home while she's single mother and lives alone with limited social support, okay, and something happened to her or her baby, you will be blamed after that. Right? Yes. That clear so far, my friends? I hope it is. Okay, so just another collection of questions. Okay. I'll choose few questions on the drugs and medication as much as I can. But the good thing is that today in the group, okay, I have seen that Dr. Madenji, she posted a nice mock test for you in the maternal medicine. But I will ask her to help with some questions also on the perinatal mental health. Okay, so at least you will have, a crisp revision of it today. Okay. So God help me with some questions on medications. Yes. Okay. Okay, so everybody answered sodium valproate. Yes, guys, thank you. Okay, so guys, for the percentage, this is another recall. I'm sorry, I'm just, looking for questions. What is the appropriate risk of a woman developing postnatal depression if she had a history of depression and first-degree family member with a history of postnatal depression? So this is risk of depression, not psychosis. Okay, so for the depression, my friend, it's 40%. Okay, so the risk for the depression is 40%. Yes. A postpartum psychosis is commonly associated with yes, it's bipolar, of course, bipolar. Okay, so I've just posted to your group, my friends, some notes about the lithium. Okay, I think I'll do it at the flashcard. I hope you like it about the lithium. Why lithium is very important in your exams. They like to ask about the lithium. They like to ask about the complication, the overall complication from the medication, especially the lithium one. Why? Again, because of the toxicity that associated with the lithium. Lithium is a medication that is generally not advised in pregnancy, right? But in case the woman, her condition only controlled by lithium, what you will do? She will receive the lithium, right? And then what will happen? They will be monitored. Yes. Yes, that's very important, okay? So, what type of anomaly associated with lithium? Yes, this is the Epstein anomaly in the heart, right? Sometimes he give you the description of the anomaly, and then they ask you about what drug or what medication can cause this, right? Okay, so can you please tell me about the Epstein's anomaly? First, it's rare, yes. There is a misplacement or displacement of the tricuspid valve. It will be, you know, like it's lower than usual. What else would be there? There will be enlargement of the right ventricle. Yes, so enlarged heart apical deviation with displacement of the tricuspid valve. Okay, so the updated NICE guideline recommended that the lithium should not be offered to women who are pregnant or planning pregnancy unless antipsychotic has been ineffective. There is increased risk of relapse if the drug is stopped abruptly. Okay, following consultation with a prenatal psychiatrist, women may wish to either stop lithium gradually or opt for an alternative or stop lithium for the first trimester before restarting in the second trimester after organogenesis. Women who are at high risk of relapse may be advised to continue lithium throughout pregnancy by a prenatal specialist. Lithium monitoring during pregnancy. First of all, fear of lithium toxicity occur when the plasma level is higher than 1.2. Okay? And it can present with nausea, vomiting, cramping, and sometimes diarrhea. Neuromuscular signs like tremors, dystonia, hyperreflexia, ataxia, cardiac dysrhythmia also are there, although are rare, but it's there. Most common electrocardiograph finding is T-wave flattening. Really? Is it all the time not appear? I'm sorry. Because I just, scroll down. Can you see it now, my dear? The point on lithium. Okay. So the most common electrocardiograph finding is T-wave flattening, lithium, and pregnancy. Remember, we should measure the level every 4 weeks and then weekly from 36 weeks of gestation. Ureteric obstruction in pregnancy and associated with renal impairment can cause lithium toxicity. Patient may be assessed for symptoms and signs of lithium toxicity regularly, and close monitoring of plasma level is essential. The women who take lithium need to deliver in a hospital, okay? And we should stop the lithium during delivery, okay, during labor. And the children, due to higher placental transfer rate during labor, okay, can be at risk of toxicity if the mother received the medication during labor. So that's why we stopped, okay? What are the manifestation in child if toxicity occurred? Low eMRCOG score, long hospital admission, and higher rate of central nervous system, and the neuromuscular complication in those infants exposed to higher doses of lithium at delivery. So he will give you the clinical picture of a low eMRCOG, okay? Long hospital admission and higher rate of central nervous system and the neuromuscular complication in those infants. Lithium level should be checked again 12-hour post-dose and post-delivery, okay? Lithium is not advised with breastfeeding. Why? Because the high level is secreted in the breast milk. Okay, my friends? Clear so far? So some notes about the medication, necessary notes or the side effect. Before we go. Okay, from the medication, we remember lithium as a mood stabilizer associated with Epstein anomaly and poor neonatal adaptation syndrome and lithium toxicity, okay? And the manifestation of toxicity, we have discussed that, right? Sodium valproate associated with low IQ, poor motor function, poor language skill, impaired emotional function, impaired behavior function, which is autism, you know? Benzodiazepines, poor neonatal adaptation syndrome, okay, or benzodiazepine withdrawal symptoms. How about antipsychotic? Antipsychotic medication are associated with congenital malformation, metabolic syndrome, gestational diabetes, and hyperprolactinemia in the mother and also can affect the baby, okay? Antidepressant can be associated with SSRI with persistent pulmonary hypertension of the newborn or congenital malformation, but in, you know, low risk, poor neonatal adaptation syndrome. And the tricyclic antidepressant, the problem with them in the safety is toxicity and overdose. That's why levels should be monitored when you give this medication. Here you need, please, to match the medication with its consequences. Sodium valproate associated with what? Which one you will choose? You match it with which one? Resistant IQ. Low IQ. Okay? Okay. So, risperidone. Risperidone is antipsychotic. Hyperprolactinemia. Yes. Olanzapine. With drug withdrawal syndrome. Or metabolic, no, metabolic, this, yes, it's a metabolic, yes, metabolic. Okay, lorazepam. Yes, it's metabolic, my dear. I'm sorry, it's metabolic. Lorazepam, it's withdrawal. Sometimes dependence as well. That's why it could withdrawal symptoms. Lithium, think there is a mistake here. Lixium with toxicity. Fluoxetine. Fluoxetine with persistent pulmonary hypertension and poor adaptation syndrome. Right? Yes, it came before in the exam as eMRCOG. Some medication and the side effect. You need to choose what is the effect and or the complication. Okay, my friends, good luck in your study. Hopefully that the perinatal mental health become a little bit easy today. Okay? Take care of yourself. Okay, and I'll see you next session, inshallah. The next few days, we will keep on posting revision notes and, helpful material for the gynecology, especially the oncology one. Okay? Thank you very much, guys, for your time. Thank you. Bye. Take care. Bye-bye.